Why should a local, state, or national government invest in, we'll change it from harm reduction to optimizing safety, when they could invest in a treatment facility?
Why is it either or?
Yeah. Well, with limited resources, you could answer that question economically and say which one is going to cause the most optimization of benefit. But I don't think that's how we do it. I think we have to understand that one leads to the other. That we know from our experience that having a needle exchange or a syringe exchange program in a community leads people to seek treatment for their drug use. We know that having a treatment program in their community reduces the burden of infectious diseases in that community. So these are all linked in a way that we have to think of it as not, these are not separate pieces. The issue is resource allocation, and when do we decide to take, if we don't have an unlimited pie, what does the current circumstance suggest we ought to be focusing on? Like right now, when we have an increasing opioid overdose problem in many states in this country, do we want to throw money at ineffective treatment programs, or do we want to throw money at primarily preventing the overdose and hope that keeping people alive long enough will allow them to want to seek care later, if so long as they haven't died yet.
I think, I'm sorry to interrupt you, but I think like needle exchange programs are inexpensive. They're not as expensive as putting up an outpatient treatment place. And you go into the community, and when you go into the community and you give out clean needles and condoms, you can provide education, you can provide resources, as opposed to just building a place where people can go when they're ready to go. And I think you could probably tell me more, but like the studies have shown how much needle exchange programs and condom distributions have decreased HIV and hepatitis C. So it's such an inexpensive way to do it.
I mean, just very quickly, when I started doing this work in 1990, there were probably 6,000 new HIV infections every year in New York City among people who are injecting drugs. The last few years, there have been like 35.
Right.
I mean, this is a success.
Yes.
This is not even a question about that. Here in Connecticut, there used to be 600 or 700 cases a year when we started the work. Last couple of years for which there's data, there have been 12 and 15. We do stand on the threshold of eliminating HIV in drug users, with the exception of outbreaks in places where there's insufficient harm reduction, inadequate, underfunded, or highly stigmatized.
Proper harm reduction with that, I think, should also be including PrEP, so
Right.
that people who are IV drug users should be given PrEP to prevent
Can you explain
HIV
what
transmission.
PrEP is?
Well, pre-exposure prophylaxis for HIV, so Truvada, being given to patients who are IV drug users, so that they won't either acquire HIV infection and they won't pass it on. And reducing the blood level to zero has been shown to be very effective at stopping HIV.
Yes. The new phrase is U equals U. Undetectable is untransmittable.
I think your question from the beginning in response, why either or, sort of there's resource allocation, but I think it also gets to harm reduction. Why can't that be built in as part of treatment? And some places do. I mean, within the same facility, you can be treating people who are at different levels of engagement or have different goals. And so and maybe it's splitting hairs a little bit, but how do we define a treatment facility in some ways?
In some ways, what Liz is talking about, you're basically going out, and it's a prevention but it's potentially the initiation of treatment.
Right.
Right? It's part of a continuum.
Right, and the mobile medical van I worked on had needle exchange, condoms, rapid HIV, rapid Hep C, screening, and the ability to treat HIV or hepatitis C.
Well, I think we've gone through a bunch of questions and really heard a lot of different perspectives and also kind of fleshed out a lot of things that have come out in this course. Are there any things that are left unsaid that people feel a burning need to say or to get across?
I think you've covered it pretty well.
Right.
Yeah.
So then I'm going to come back to my original thing, which is I think this is a very optimistic time to be involved in addiction treatment, that we have a lot of research, we have policy changes, we have interest among healthcare providers, we have collaboration that we've never had before. And this is just a really exciting time to be a part of the addiction treatment system and a very hopeful time for patients and for families who are struggling with this disorder. So thank y'all for being a part of this.
But we need others.
That's right, we need more. We need more.
So to those of you who are out there, join us.